I'd just like to close with one clarification. Assemblyman Thurman asked about SSI recipients not being able to receive CalFresh, and just to let you know that California is the only state in which that is true. We're the only state that operates under the cash-out system. Go California. Thank you.
Thank you for that. That was heart-rending. That's something that should not be in an economy as rich as ours, the 7th largest in the world, not just in the state, in the world. Dr. Chodos.
Thank you so much. Yes, my name is Anna Chodos, and I would like to start by thanking the Assembly Committee on Aging and Long-Term Care and the Assembly Committee on Human Services for this opportunity to speak here today. And I've been specifically asked to talk about how poverty affects health in older adults and healthcare use. Just to give you a little bit of background, I'm a primary care doctor and a geriatrician, and I practice at San Francisco General Hospital. I practice in the outpatient setting, and I also have a specialty clinic for older adults. And I'm going to talk a little bit about the health effects of poverty, specifically in older adults, and some of my experiences with older adults facing poverty and caring for them in the medical setting, and then the impact I've seen it have on their health. So what do we know about the health implications of poverty in older adults? Just really quickly to frame the issue, we know that older adults use more health care, so health is a very important issue. So the 2013 report from the CDC, the State of Aging and Health in America, noted that 2 out of every 3 older Americans 65 and older have multiple chronic conditions, and treatment for this population accounts for 66% of our healthcare budget. The growth of the older population, we know, is what we think will contribute to the projection that by 2030, healthcare spending will actually increase by another quarter. So we know that healthcare costs and use are on the rise. And specifically around health and poverty in older adults, I want to touch on 4 key issues. So first, what we know about how poverty affects health and how they're correlated. Secondly, how we know that poverty affects disability and material needs over the lifespan and how that's going to be increasing. And how poverty, third, how poverty affects specifically certain medical diseases and healthcare use. And finally, how poverty affects caregivers, which I think is underappreciated and under-discussed. So how poverty and health are related and influence each other, this is the kind of research that goes back literally decades. It's very well studied across many countries. And we know that there's actually a gradient. So your poverty over a lifetime affects your risk of chronic conditions and mortality. So lower career earnings earlier in life affect mortality and retirement. I think personally what's really humbling and scary to me is that we're now seeing these disparities increase. So if you look at life expectancy, we all talk about how people are living longer. We're going to face this aging population that's growing. That is true, but that is not as true in lower income people. So their life expectancy increase has stopped, and in some cases is decreasing. So, and obviously people look at this very closely, but that's sort of the most recent take on it. The other thing that I think we can all appreciate, and we've heard some from some of the other testimonies, that poor health causes poverty. So we know that people who are in poor health don't have as high lifetime earnings and have less ability to work over the span of their life. And I'm surprised I haven't heard it, but medical expenses are one of the top causes of poverty, if not the top cause. One estimate I saw from a profile of older Americans, a report published in 2012, was that older Americans spend 12.7% of total expenditures on health, whereas the rest of the population spends 6.9%. I personally spend maybe 0.5%. So that was a really staggering number to me. So we also know that poverty affects disability, and I think disability is a huge issue, and a huge issue for our thinking around how we're going to distribute social resources. So it's also very humbling to note that disability trends overall are starting to contract a little bit. So what we call ADLs, activities of daily living, the most basic functions to be independent in your home, bathing, dressing, eating, those overall we think are decreasing that disability in older adults. However, we do know that even as people live longer, over half when they reach late 80s, 90s, will have an ADL disability and need help to remain independent in their home, and that the disability trend, once again, is not relevant to low-income populations. So ADL disability is increasing in that population. So we're talking about two different groups of people in some ways. And we've also heard just again and again in really, I think, powerful ways how much social needs are affecting older adults. And I think in the healthcare setting, we see this all the time, and doctors agree. So a Robert Wood Johnson survey interviewed primary care providers, and 85% said that they felt that unmet social needs were affecting the health of their patients. That went up to 95%, although it couldn't go up really that much higher, but it did go up to 95% among primary care doctors like myself who work with older adults who are low income and in underserved settings. And from our own hospital, there was a study interviewing patients at home after they left the hospital, and they identified the things that were preventing their recovery. And those things were functional limitations that they didn't have help with, self-care tasks that they didn't have help with, social isolation and lack of support, and challenges from poverty in their built environment. Those are their words. That's what they found. And you may think, well, okay, maybe they're going to recover more slowly. But actually, we know that disability in older adults, 50% of that is acquired during a hospitalization and in the period afterwards. So it's a huge contributor to what seniors ultimately need in the community, is that period of time and that ability to recover from acute medical illness. So how do we know, or what do we know about how poverty is affecting specific medical illnesses and medical conditions? So we know that material insecurity and low income does lead to poor health outcomes in multiple diseases. For example, low income is associated with earlier onset of heart disease, preclinical and clinical, meaning things we can detect but aren't clinically significant yet, and those things that are significant like a heart attack or heart failure. We know that neighborhood poverty and personal poverty are associated with heart disease and cognitive impairment and dementia, which is something I deal a lot with, and again, haven't heard addressed that much today, but is a huge contributor to need for social services in the community. There's also an incredibly strong association between poverty, nutrition, and health. So those three things. And food insecurity has been shown to be associated with, again, poor functioning, poor overall health. It's also associated with much worse diabetes. So Dr. Hilary Seligman, whom I work with at San Francisco General, she calls this a cycle of food insecurity and chronic disease. Because if you think about it, you have difficulty with food that imperils your nutrition, which further imperils your health, which further leads to more economic and food insecurity. And she found, which is really fascinating, that there was a 27% increase in hospital admissions at the end of the month just among low-income people, and that was all related to low blood sugar, which we know is associated with food insecurity. So, and as Ms. Costa said quite eloquently, we know that poverty increases the risk of medication security and the inability to access medical care. This was true even among Medicare beneficiaries, who in a survey from 2008, 16% of them said they delayed care in the previous year due to cost concerns. And due to that delayed care, they found that they suffered increased stress and anxiety, actual physical pain, likely because of their conditions, and worsening of their medical conditions. The other thing I have to mention, particularly in San Francisco, is housing costs, which we've heard a lot about. But in terms of its effect on health, housing instability, which was just considered housing instability if people self-reported difficulty paying rent, mortgage, or utility bills for their home, is associated with poor health. So it's associated with not having a usual source of care, postponing needed care, postponing medications, increased emergency room use, and hospitalization. So just across the board. And mortgage delinquency itself was also associated with cost-related medication non-adherence and food insecurity. And finally, unmet needs, especially among older adults with dementia, we know leads to institutionalization, which is very costly. So one study looked at unmet needs in dementia and the likelihood of admission to a nursing home and found that it was increased in people who said they didn't have assistance to meet daily needs, which is, I know, somewhat obvious, but it's I think, a very clear reflection of the fact that if we were able to provide people more support, they could stay in their homes. And finally, caregivers. I do want to mention caregivers. I see how poverty affects them all the time, and it's an absolutely enormous part of our informal economy. 80 to 90% of caregivers are unpaid. That's just astounding to me. And approximately 20% of our adult population, people over 18, provide unpaid care for older adults 50 and older. So this is a huge group of people who's providing care. Often caregivers are women, family or friends. They're often older themselves and untrained. And most provide approximately 20 hours of care a week. So a high burden of caregiving has been associated with increased poverty for the caregiver, worse self-care and health for the caregiver, and depression. And in the care recipient, it's been associated with increasing nursing home placement and abuse. So I think it's an important issue because I've seen it really imperil the health of the caregivers themselves and set them up for an unstable older age. So finally, I think that, I've heard it many times myself, but health is wealth, and wealth is health. So it's a very reciprocal relationship, and I hope some of this has provided some evidence for that. And I really feel that I was clearly very motivated to come here by my patients, and I really just wanted to briefly relay a couple of scenarios that I have seen that have really made it stark to me how health and wealth are so interconnected. So I have one gentleman who I've actually known for 7 years now, which surprises me, who was an immigrant to San Francisco, worked his whole life in odd jobs, did not have a lot of savings. And when I met him with his benefits, felt like he couldn't make ends meet, and so was collecting cans to make extra money. Literally every time he came, he'd have a little bag of cans. And the problem with this was he had a severe neuropathy, and he actually didn't have feeling in his hands or legs, and he would constantly injure himself. And so we were often trying to find ways to help support him in the community so he didn't have to collect cans. But when I sat down with him and he just marched through what he made every month and how was he supposed to make ends meet, even if we did provide extra services, I sort of agreed. I didn't have a better plan either. I think I just sort of wasn't really able, I think, to connect him ultimately to services that could sort of help him get out of this cycle. The other gentleman I know actually is very similar to Ms. Costa in the sense that he's just above the limits of where he can get services, and so we weren't able to get him an in-home supportive care service worker. But he lost housing for some unclear reason, and lives in the Tenderloin district of San Francisco, which is known as a somewhat dangerous district. And unfortunately, he's very isolated now because he's very scared of his neighborhood, and he has a terrible gait problem, and so uses a walker, very vulnerable guy, and says he only ever carries a few dollars in his pocket because he's pretty much always robbed when he walks down the street. And so with these few dollars, he goes to Walgreens, which is the place he feels safest walking to, and buys his food there. And for me, as a physician, that's made it very difficult to manage his heart failure because he tends towards the pre-prepared foods, which have a lot of sodium. And we've had a lot of struggles over his health conditions. And just one further example, there's a woman who I visit at home now because she is very slow, and she has a lot of swelling in her lower legs for a couple of reasons. And she waits for paratransit, which is a great benefit, but unfortunately they often leave her because they'll let her know that they're there, and it takes her so long to get to the door, and she doesn't feel safe waiting outside. So I've taken to visiting her at home, and the reason I do sort of need to see her frequently is she had a bad exacerbation of all this swelling, and she had a lot of edema on her leg, and got some wounds from all that swelling and fluid. And the problem with that was the medication to help her get some of the fluid off wasn't really feasible because her landlady threatened her with eviction if she kept flushing the toilet as much, so she would need to take a pill to use the restroom. And so she stopped taking the pill and ultimately got this terrible wound. And our main battle for her has been trying to get her better housing, and it's been absolutely impossible. And here's a woman who lives alone, has multiple medical problems, cannot really manage her medical conditions, truly out of fear for her landlady, and is sort of does have some benefits, but I think where some of these things more abundant would be in a much better position and be a lot safer. So really, in conclusion, I just want to thank you again for the opportunity to speak a little bit about health and poverty, and I'd be really happy to take some questions.
I'm astounded by your testimony today. And I have to give you a gold star, angel wings, as well as a crown, because I didn't know doctors still went to visit people who were sick. And I really think the world of you. At some point, I hope we'll be able to talk again, and I hope maybe we can convene a group of people in a room that can see that poverty is really bad, and billionaires need to help. We have a lot of billionaires. We need help. So I thank you for your testimony.
Thank you.
Rachel Cavilla?
Caraviello.
Thank you. Oops.
Well, thank you so much for the opportunity to speak to you today. The perfect segue from Dr. Chodos is how impossible it has been for her to improve her client's housing situation. So I am here to talk about how housing, as sort of just a basic foundation, contributes to food insecurity and health challenges, and what that looks like in Los Angeles specifically. I work with an independent private nonprofit called Affordable Living for the Aging, and we surface all of Los Angeles County. The common challenge that people have is they can't afford the fair market rent, but then within the group of older seniors who need financial assistance to afford rent, there's a lot of variability around what's the best intervention for them. Mm-hmm. So as such, we provide 3 unique models: permanent supportive housing, which is specifically for homeless older adults who are aging on the streets and need intensive on-site services. We also provide shared living residences, which help deal with and reduce social isolation, and are really best matched for individuals who live fairly independently but still cannot afford the fair market rent. And then finally, our signature program is a roommate matching service, sort of like the 80s TV show Golden Girls, although it is for men as well. So we match individuals who are widowed, divorced, or never married to share homes. And by living together there and by being interdependent, they're able to maintain their independence. And I think that's sort of the big why we do what we do is at the very basis of housing is this idea that you really need to have options and choices in order to maintain your independence and your dignity as you age. And so we really think of housing as a command center, or for those of you who like sports, depending on what the sport is, a home court advantage or a home field advantage, where as an older adult starts to have limitations in functioning, this is the environment that they know the best and that they've developed routines within and that they've really figured out how to compensate and navigate their environments. And from this stable platform, they're able to access in-home care, Meals on Wheels, and other sorts of services that are already available in the community, but that are really difficult to piece together if where they live keeps changing, or if in the worst case scenario, they have no stable address. So as many of you know, housing is the largest item in the budget for most households. So a small change to someone's housing costs or to their financial income makes a huge impact. And as incomes stay flat for most seniors and the cost of their housing rises, many are left with nowhere to live. So this is our client, Paul, a retired LAUSD school teacher. And he was told that he would have to wait 4 years for an affordable senior apartment. The reason Paul was told he'd have to wait 4 years is because he's among 125,000 low-income seniors in the city of Los Angeles, vying for approximately 7,800 affordable senior apartments. So that means 16 seniors are competing for every one apartment. It's a little akin to finding the golden wrapper in the Willy Wonka chocolate factory. You know, it's a combination of luck and timing and really being able to wait out those 3 to 4 years in order to get access to the type of housing that's subsidized in a way that it's affordable to you. When we talk about housing affordability, we're talking about paying no more than 30% of your income towards housing costs. As was mentioned at the very beginning of this hearing, throughout the state of California, the majority of older adults living in poverty pay well above 50% of their income towards housing, and this is considered a severe housing cost burden. The chart that's up there right now is based on the average asking rent in Los Angeles County for a studio apartment with 1 bathroom compared to the maximum grant for SSI, SSP. So the gap is enormous, and the point is simple, that there's just not, most people don't have enough resources to access apartments on the private market, and so they're really relying on nonprofits and government entities to provide some of that housing that closes that gap and eliminates it altogether. The consequences of high housing costs and low fixed incomes are the same that you've heard from many of the other experts. People spend 43% less on food, 59% less on health care. This is from a study that the Joint Center on Housing Studies at Harvard University put out last year called Housing America's Older Adults, Meeting the Needs of an Aging Population. Even more locally in Los Angeles County, the Department of Health Services did a phone survey last year, and among individuals who answered that they had trouble affording housing, 54% of them were unable to afford medical care and dental care. So there's significant trade-offs between having to spend the majority of your income on housing. In addition to that, there are a portion of older adults who the high housing costs and the low fixed incomes puts them in the worst case scenario of a position of homelessness. Did you have a question? No. Okay. And while being homeless is easy for no one, it's particularly difficult for individuals who is facing the vulnerabilities of aging. So homeless older adults are on the streets. They have an increased rates of chronic disease. They have higher levels of frailty. They're dealing with geriatric conditions around increased risk for falls and memory impairments. And the homeless services system, which in they're trying to navigate, isn't designed for them. So shelters are not accessible. A lot of contagious diseases get passed around in shelters. There's no access to refrigeration for medication, and you don't get steady rest on a regular basis. And their studies have also showed that there's no regular access to health care. So several years ago, Shelter Partnership, an advocacy organization in Los Angeles County, did a study on homeless older adults living in the largest emergency shelter in the county, New Image Shelter. And these are some of the demographics of that population. They looked at 1,500 clients, and of those 1,500, 228 were over the age of 62. And so you can see the disparities in the population that's in the shelter and over 62. The important point about this slide is that even when we're talking about homeless older adults as a subset of lower income seniors, there's 2 groups within that group. And the first group are individuals who are being homeless for the very first time. So when these files were looked at, they had been homeless for only a month. And then the other group, which makes up about a third of the population, is the group that's been chronically homeless many times off and on and over the course of several years. So for people who are homeless for the first time in late life, so about a third of that population, their primary barrier to regaining housing stability is just affordability. They don't need as much intensive supportive service. They just need access to housing that's affordable. The most common reasons that put them in that situation was poverty and that had them in a precarious housing situation, and then that one crisis happening. And the most common crises to happen are a mental health issue, relationship breakdown, an illness, or an unexpected job loss. For the population of seniors who's aging on the streets, the most appropriate intervention for them is permanent supportive housing with intensive case management and on-site services so that once they're in housing and paying only 30% of their income towards rent, they have the support to maintain their housing, both social support, mental health support, and health care. This is Bonnie Brae Village, which has 92 units. It's the first project in Los Angeles County to be specifically designed for homeless seniors over the age of 62. And it's a mixed population building. So 46 homeless older seniors live side by side with 45 regular low-income seniors who also needed access to affordable housing. This is James, Doris, and Henry, all of whom moved in with the very first group of seniors at the end of 2010. And as another presenter mentioned, the population of homeless older adults in Los Angeles County is rising and is expected to continue to rise. And that's because a lot of the factors that influence housing security are going to continue to persist or get more severe. There people living on low fixed incomes, people are living longer, and there's not enough affordable housing, so it's a basic supply and demand equation. The other issue, which I think is becoming a little bit more of an opportunity and is where this sort of cross-cuts with healthcare, is that as healthcare reform shifts services to community settings, one of the biggest barriers is going to be, well, do people transitioning out of nursing homes have access to affordable housing? And how do we make room for them when individuals in the community are already struggling with this? But if people prefer to receive services in the community, if it's less expensive to provide services in the community, then they also need the housing from which to access those services. And I would recommend that the committee consider increasing the financial assistance for seniors, but also increasing the supply of housing in units that are set aside for seniors. We can't address the issue of homelessness unless we actually build more housing. And so there are some bills out there that are poised to do this, and I would encourage continued support of those bills. And then also to do what the Elder Economic Index does, which is include the cost of housing in a very localized level within eligibility criteria for existing programs. Thank you so much.
Thank you so much. I was a little distracted because he had given me some kind of good news, and I was, before we go out, at least say that. But thank you so much. You've given us something to shoot for. All three of you have just done a wonderful job today. I thank you. It's almost 4 o'clock. We have 2 more people to wrap us up. So could we say thank you to you? I don't even have time for questions right now. But Scott Graves, Director of Research, California Budget and Policy Center, and Cynthia Banks, Director, Community and Senior Services in Los Angeles County. I also want to have time to hear from you. I'm one that thinks it's very important. If you've come in here today, you have something to say that we should hear it. So now we're going to have some takeaways, right? We're going to wrap